Well, welcome everybody. Good morning, good afternoon, good evening. My name is Dion Filmer. I'm the director of the World Bank's Development Research Group. It's my pleasure to welcome you to this June edition of our Policy Research Talks series. These talks provide us an opportunity to present work coming out of the World Bank's research department with the goal of sharing the findings with colleagues inside and outside the department, along with others outside the World Bank. With that, I'd like to welcome our online audience, both on WebEx as well as YouTube. Today, my colleague Tristan Reed, who's an economist in the macroeconomics and growth team, will discuss the responses of multilateral organizations in the face of the COVID-19 pandemic. The talk will draw on 5 research papers that Tristan completed with co-authors during the pandemic, although it's still ongoing, including a synthesis article that is forthcoming in the Oxford Review of Economic Policy. He'll be highlighting successes, misunderstandings, and lessons learned, and then Tristan will reflect on how multilateral institutions can more effectively respond to future public health emergencies of international concern. Tristan's research is generally focused on topics in industrial organization relevant to public policy. Alongside his research activities, he's served World Bank clients in Africa and Asia in particular, with a focus on developing strategies to achieve structural transformation through export diversification. As you can tell, he has a diverse set of interests, although there's a common thread through everything. We're extremely grateful to have Michael Kent-Rensen as our discussant today. Michael is a senior economist in the Health GP, the global practice, based in the World Bank office in Geneva. He is the World Bank's focal point for engagement with Gavi and COVAX, who've been big players in the COVID-19 pandemic era, of course, and has served as Gavi board alternate and on the Gavi Program and Policy Committee since 2018. He's part of the team that developed a new mechanism that allows countries to use World Bank financing to purchase COVID-19 vaccines beyond the fully donor subsidized doses they are already receiving through COVAX. I'll ask Tristan to talk for approximately 40 minutes, after which we'll hear from Kent for up to 10-15 minutes. We'll conclude the sessions with questions and answers from the audience. If you have a question, please use the raised hand option in WebEx or signal to me in the chat that you have a question, and I will try to call on you and ask you to pose your question out loud. If you're following on YouTube, please submit your question in the chat and it will be relayed to me. Just a reminder, we're recording the session and please mute if you're not speaking. With that, over to you, Tristan.
Great, thanks very much, Dion. Let me just share my screen. There we go. You should have the presentation. All right, so let me get started. So just as a roadmap, I want to talk about 3 things today. So the first will be just to describe international inequality and both the human and economic effects of COVID. We're 2 years into the pandemic. It's not over. And I just want to start by showing how that's affected countries very differently. I then want to talk about how countries cooperated to respond to the pandemic. So this is the word multilateralism. That's 3 or more countries working together. And I think it's been made very clear that the part of the recovery of COVID-19 and to any pandemic requires cooperation with countries because for two key reasons. One is that there won't be a recovery in economic sort of growth globally unless all countries are sort of relatively secure from the virus. But also that as we've seen, new variants can emerge in other countries and harm other countries. And so for these reasons, countries have a strong incentive to work together to stop a pandemic, and we want to assess how well they did this time. And then the last, and this is based off the most recent paper in the Oxford Review of Economic Policy. I claim, and you can tell me if you believe this at the end, that a faster and more equitable response is possible to the next pandemic, but also with about the same resources that we had in COVID-19. So I want to sort of take us, hindsight is always 20/20, but I want to learn from the experience of COVID-19 to see how we could do better next time. And I'll just say, as a caveat, I'm an economist. I'm not a clinician or an epidemiologist, but I'm going to try my best, in this talk to give you, both the health perspective a little bit and also just be very clear about the economics. Okay, so thanks. So to start, I want to share this picture from the proceedings of the National Academy of Sciences, which gives very good context. It just shows the probability over time of a disease outbreak that's worse than the 1918 influenza, or the Spanish flu, as it was called. In 1600, 1700, you see that probability is about 0.5, so it's basically a 1 in 200 year event. By 1918, it's about a 1 in 100 year event, and by 1959, it's almost a 1 in 50 year event. And so there's a lot of literature on this, but I think the basic takeaway is that this is largely due to increasing population density and economic growth, interactions between humans and animals, interactions between humans and other humans. We've learned a lot from the pandemic about how that can increase, how diseases are transmitted, and we've really seen that over time. Another thing, though, that's interesting is that you see this massive drop-off in the probability after 1950. And so what happened then? Well, it was a new technology. The polio vaccine was developed in the 50s and became widespread, and vaccine technology broadly has been distributed and made sort of almost compulsory for young people across a number of diseases. And so we see that actually because of vaccines and other public health responses, actually disease outbreaks, even though they're happening more frequently, we control them earlier. And I think that COVID is a great example of this. Now 2 years into the pandemic, there are over 6 million people have died. An upper bound of accounting for measurement could say up to 18 million. But that's still less than died during the influenza pandemic, where the range is 20 to 25 to 50. And this every death matters, but because of vaccines, we've been able to avoid sort of a pandemic as bad as the 1918 flu. So the policy context for this whole talk is say, well, because everyone is living closer together and these diseases do emerge more frequently, how can we best prevent them? So prevent these disease outbreaks from growing very large. And then also, when they do grow large, how can we make sure we respond quickly? So in the case of the coronavirus pandemic, could we have had vaccines earlier in larger quantities and to have more access across countries is going to be an important question. Okay, so that's just high-level context. Just to say, where we are with the coronavirus pandemic. So it was devastating, as I said. 6 to 18 million people lost. But it's also abating. So for some time now, diseases, sort of new daily deaths have been lower than they ever have been before. I wrote a paper in early 2021, which said, how to end the pandemic by March 2022. The goal there was to say, well, if there's no mutation and you immunize or about 60% of every population, you could get herd immunity. Now, as we caveated, the disease could mutate. It did mutate, which means that there's even some more immunity from prior infections, some more fatalities, but also immunity from prior infection. And so still, even with mutation, we have the Africa WHO, the European Union, other regional agencies saying, the emergency phase of this is over. The disease will, continue. We'll have outbreaks, but it's no longer the crisis it was in the last 2 years, and that's largely due to vaccines. Vaccine, as I said, it's driven the recovery. It's driven the response to lots of outbreaks since the 1950s, but coverage has still been highly unequal. So this is something that is continuously highlighted. In Africa, especially. So I'll say, there are many countries that now have 2 doses administered for every person in the country. That's the sort of middle green color. You see Canada, parts of South America, China, Australia, Europe. US also, relatively has pretty good coverage. India and Russia a little bit less so. But then largely in Africa and in other regions, you see Afghanistan, we still have very low coverage. So that's sort of less than 50 doses per 100 people. And in Africa in particular, in total, there are about 18 countries that have yet to vaccinate even 10% of the population. So, one question is, how could we have accelerated this? I think at the moment, vaccine supply is not a constraint. So low-income countries they've immunized about 12% of their population on average, but vaccines have actually been delivered for 24% of the population. So it's that, the challenge of last mile delivery that's really binding. But earlier supply was a constraint, and so one question is, could we have got that supply delivered sooner so that the health systems that existed could take it on? So I just want to talk a little bit about the inequality of health effects across countries. So very early in the pandemic, many believed that both the economic and health effects would hit low-income countries the hardest. And this really hasn't been the case. So this is a chart that Penny Goldberg and I made for the Brookings panel in summer 2020, but I've added the new data, and it shows deaths per million. So we're normalizing by population for different income groups of countries: high income, lower middle income, upper middle income, and low income. And then I've also separated out both China and India because together they're about a third of the world's population. They're both middle income countries. Just to give you some flavor of the country specific experiences. And what you find in this picture is quite clear, is that this has been a pandemic where on a per capita basis, it's high income countries and upper middle income countries, excluding China, that have borne the brunt of mortality. In regression analysis, Penny Goldberg and I found that this was you could attribute this entirely to demographic risk factors. So an older population in high income countries, and also greater obesity, which is quite high, especially in upper middle income countries. And in low income countries, you have half the population under age 20, about a third of the obesity. And so that, I think can explain a lot of this. We found this as, there's still vulnerable people in every country, and so they need care. But still, I think this was early on a cause for optimism, because it meant the countries with the weakest health systems, the poorest ones, would not have, as much pressure on them, at least relative to high income countries. And it also meant that, lockdowns, which could be costly, especially for poor households with no buffer savings, they could be released earlier. And others made this argument too, like Mushfiq Mubarak at Yale said, especially in low-income environments, people need to be able to go out and work. So the policy of closing down the economy was not as it has to be treated differently than in a high-income country. So we found this as a case for optimism, but at the same time, it raised an issue. So if pandemic response is a public good, and we say, every country's not safe until everyone is safe, then, if the disease burden is higher or lower in certain places for demographic reason, those countries might, underinvest, for instance, in vaccination. And so, the international community took it on itself to deliver, vaccines and other health products to low-income countries to keep the burden lower in those places. And that's what I'll talk about in the paper. I want to just, in the next slide, I want to talk about, obviously confirmed deaths are not all the deaths that happened in New York. Remember, there was underreporting of deaths in retirement homes. The WHO has actually estimated, how much death was missed by the confirmed statistics. And I'm showing you these now on the same scale. I think here, you see, especially in upper middle income countries, excluding China, and in India, there were, much more mortality than was recorded. But at the same time, you do see the same pattern, that the low income countries, the blue and the purple, and the lower middle income countries had the lowest, excluding China, the sort of, lowest death. So this is just giving you a flavor of the pattern. I also want to highlight one thing that, so if you look at India and China, you see how, very different choices of governments can lead to different outcomes. So here in in both India and China, you see that early in the pandemic, actually, they had fewer deaths than were expected, so from other causes. That could be attributed to the lockdowns, which on net maybe save some lives. There was a lot of debate about that, actually. But then you see later India took a very different path, right? So and that could be a combination of releasing lockdowns, but also limited access to vaccines. China invested much earlier and had supply much earlier. So one question we're going to answer here is for all these groups, regardless of the inequality, how could we have brought the medical countermeasures, especially vaccines, earlier and reduced this excess death? Okay. I want to say a bit about the economic effects. We've talked about the human effects. Again, there was a lot of inequality. So, before the pandemic in 2019, there was what's called income convergence. So middle income and low income countries, where you can see this in the blue box, were growing faster on a per capita basis than high income countries. So that meant that, it'll take a very long time, but income, everyone will eventually have the same income. During the pandemic, the costs, consistent with the mortality effects being higher in high income countries, the economic costs were also much greater there. So on a per capita, so there's still a global recession. Income per capita goes down in every country, most in the global economy, including these three groups. But the decline was worse in high income countries. Then in 2021, you had also this unequal recovery. So high income countries spent a lot of money accelerating their growth, and so they recovered a lot of the losses. Low income countries also grew faster, but not as much. And then how is it looking forward? So in 2022, so these are all, by the way, the recent numbers from the World Bank's Global Economic Prospects, which were just released last week. So the forecasts are current. Before the Ukraine war, actually the forecast for 2022 was that every region, so every income group, would grow faster than in 2019. So that in my view is a pretty positive recovery. We've seen now that the Ukraine war has had some effects. So low and middle income countries will be growing slower than 2019 and also slower than 2020 than high income countries, but that recovers in 2023 and 2024. So, looking in a little bit of a long term at 2023, 24, we can still expect growth that's faster than 2019, and also income convergence. So I think this is a pretty positive story overall, if you take a slightly longer term view. Okay, so now I want to talk about how countries responded together to COVID, and what the lessons are for future pandemics. This is a chart, and I think this was the main immediate economic effect of the crisis, is that in March 2020, global investors just sold all of their EMs, not all, but more than ever before at one time, their EM stocks and bonds. So it's called a sudden stop. Everybody's selling bonds and securities. The consequence of this is that the financing costs for governments in emerging markets balloon. So you sell bonds, the price of those falls, and then the interest rate goes up because the interest rate and the price move in different directions. And so this is just for a lot of group of countries, 500 years, 5 percentage points. These are in basis points. It's just showing this incredible jump in borrowing costs for some countries. So this is at a time of global emergency. The private market is saying, we don't want to help, governments in low and emerging countries, or at least we need to be compensated a lot to do it. So this was an early focus of the multilateral response. So the G20 economies, the finance ministers had a call, and they announced in March that they were going to support countries. Immediately, this provided some relief to developing country, or to these emerging markets. You can see the prices fell in a lot of them. So that just announcing support was helpful. But then this is interesting, and I think it shows a bit of the limits of the multilateral response. So later in April, they announced what is called debt forbearance. So they said, you're going to owe us interest, but you can delay paying that interest. It's still going to accrue, so you're going to owe it in the future, but you don't have to pay this year. And that was I think a useful thing. It helped give countries some room to think about how to respond to the pandemic. But what's interesting is that this actually immediately after, you see in a lot of the countries, so in Nigeria, for example, actually the interest rate goes back up. So one way to interpret that is that the market actually evaluated, it didn't think Nigeria was going to default. It thought it was going to pay on time. So now when Nigeria, if it delays payments on the private bonds, that's a increased risk for the bondholders. So this is, I think, shows that just by changing the interest schedules, let's say, there's probably a limited ability to affect sort of the borrowing costs for countries. And still, today this only goes to July 2020. But even today, these costs are still higher for countries. So countries are having to pay more to respond. Where I think the multilateral institutions were very successful was providing a huge amount of finance on their scale, much cheaper than the market. So, the World Bank delivered 204 billion to governments in the calendar years 2020 to 2021. Over half of this was to governments. And, the key thing to highlight here is that the interest rates on these loans were much lower. So 65 to around 1%, 65 basis points to 115. And which is much lower than those earlier rates I've showed you. So, it was said in public recently that the World Bank has a fetish for its AAA credit rating, and it should maybe be riskier. In an emergency, the attractiveness of a low interest rate is exactly that. So the bank was able to provide very cheap credit in this time. If it didn't have a AAA credit rating, it would have to offer more expensive credit. And I think it's also important to highlight that this didn't just support health, it helped countries maintain all their other programs. And one thing people might say is, well, you're coming in with cheap finance, maybe you're just allowing them to pay off the private bondholders that are getting higher interest rates. That's still good, right? If you lower the cost of financing for a government, that frees up money to do all sorts of things. So I think this is where I think the multilateral system really worked as it's supposed to. It provides cheap capital, and in an emergency that's especially useful. So now I want to get into the public health crisis and response. So the main thing here, on a global scale, was this initiative of the ACT-A, or the Access to COVID Tools Accelerator. I'm pretty sure the name was invented by management consultants. So tools are vaccines, therapeutics, and diagnostics, and also personal protective equipment. And the idea behind this was to say, let's pool money together. And part of it was intended to develop new vaccines, because that very early on, we didn't even have vaccines. But then it was also intended to purchase those vaccines and other health products, and then deliver them for free to low and lower middle income countries. So here, you just see how that evolved. They pitched 38 billion. There were some cost adjustments, which I think highlights how difficult figuring out a real number for these things is. And then, in the end, they raised about 18 billion, most of which was for purchases of vaccines. And I should say 2/3 of these commitments came from the G7 economies, so the US, Germany, Japan, and others. And it's interesting to compare the numbers relative to what those countries spent, on their own supplies. So the US actually spent 55 billion, in total on vaccines. It's an estimate from the economic report of the president. But it only spent 12 billion actually purchasing vaccines. A lot of the other money went to either just rolling out the vaccines or subsidies for development and research early on. And so one interesting point is that because the US and other countries spent so much on development, this for these purchases for other countries could restrict their purchases to a certain extent. to just advanced procurement because they had been developed already. And so just to summarize, this amount of money, I think I showed in a paper early on with Ruchir Agarwal that this amount of money about would be enough to vaccinate 60% of the population of low and lower middle income countries. So those groups I showed you before. I want to have a slight interlude on sort of testing. So testing, as you saw back here, it only received a diagnostic 1.4 billion relative to diagnostics. So why is that? So I did a cost benefit analysis here with a big research team early on, and what we did is we highlighted 5 use cases for vaccination. So this is clinical triage. So that's someone coming in and saying, do you have COVID? If so, I'll put you in a room with other COVID people so you don't infect other patients. At-risk worker screening, that's for healthcare workers or transportation. One is just measuring the rate of infection in the population to trigger or avoid a lockdown. Test, trace, and isolate, and also border screening, which could, protect people at the border, but also protect a country from a large outbreak. And so, what we found, so Peter Sands at the Global Fund, asked us to convert this into a return on investment. Well, let me say first, so we calculate for each of these scenarios that, the number of tests you need to save one life is relatively small. So even for border screening, 8,000 tests, let's say they're 10,000, or sorry, they're $10 a test, that's 80,000, 90,000 to save a life, which is, I think a pretty good value. Peter Sands asked us to turn that into return on investment. So if you value life in some way, you can say this is, 3 to 41%, sorry, 3 to 41 times rate of return, which is really high. So these are all really good investments. So the question is, why didn't we do this as much? And I think the answer, one answer is that countries, have budget constraints and they have to allocate them across things. But consistent with that is this thing which we show in the lower corner here, which is that the returns really vary a lot with prevalence. So if you have very low prevalence of a disease, it's the tests you need to save one life are many, many, many. And so you can imagine how countries that felt, okay, we have something under control, might not make advanced purchases for diagnostics that they need, 6 months into the future. That requires, I think some foresight and some ability to stomach the uncertainty. So, that's just some ideas there. But I said, overall, there should be more investment in diagnostics, but we can understand, I think, about why countries may not have because of this sensitivity. So, back to vaccines. I showed you earlier coverage today. This was in August, and this was where this hashtag came out called vaccine equity with 1 E. And it really was true at the time that only a few countries had access to vaccines. China had a lot, the United States and Europe and Chile and a few others, Arab Emirates, had, but many of the countries couldn't get access. So, in a paper at that time, Mamta Murthy at the World Bank and I, tried to describe sort of why could this be? And one hypothesis was that, well, only a small number of countries have vaccine production capabilities. We call these the G10. So it's the G7, which is the US and Japan and some European countries, Canada, and then China, the EU, and India have most of the production capacity. And we said, well, maybe they're prioritizing their own populations. This is the export restriction hypothesis. And we said simply, at the current production rate, if they said, we're going to reserve as much as we need for 80% of our populations, how long will it take for supply to be available to other countries? And we forecast that actually by the end of 2021, there'd only be about 270 million doses if they choose not to export anything to other countries. And then, that I think highlights that, it is important where, that countries can secure their supply. And if you're relying on only a few countries, that can be a problem. At the time, there were really limited ways to expand supply to other countries, and so we charted out these 6 scenarios. So one would be just to approve effective vaccines. So that was at the time, Novavax had these phase 3 trials that were successful, as well as some vaccines in China, but they hadn't yet been given regulatory approval. So that was one thing. The second highest impact would have been, for the CureVac vaccine, which was sort of found to be ineffective. We said, well, you could take the manufacturing capacity from that and give it to either Pfizer or Moderna. That could be effective. That didn't happen in the end, I think, for respect of property rights. And then the other ones was to delay boosters, delay second doses, for those with prior infection, as was done in France, delaying the youth who have a lower mortality rate, and then authorizing half doses, which some research showed that basically you could get the same effect of Moderna, for example, by cutting the dose in half. And they've actually done that one now. But the point from this is that there were sort of very few things that could be done in 2021 to expand supply for low-income countries. And so I want to ask in the next slide, sort of what could we have done about that? So, I think it was clear at the time that, and this is from the paper in Oxford Review of Economic Policy, also just released as a World Bank working paper. It's called Financing Vaccine Equity. And what we do there is we say, okay, so the data don't, there's 2 hypotheses. So one is that the countries that were producing were hoarding the vaccines, and they were, restricting exports, and it was impossible for lower middle income countries, LMICs, to get vaccines at all. But another hypothesis is that, well, the market was open, but supply was scarce and it was rationed through queuing. So, if you placed, the people who placed orders earlier got orders. And this is actually what, CEOs of vaccine companies said. So Dr. Bourla at Pfizer said, I had asked heads of state by letter to place order, but when they finally did order, the doses had already been allocated. So this is another hypothesis is just that countries didn't order early enough. And so in this paper with Ruchir Agarwal, we collected data on over 460 vaccine contracts, almost 460 advanced purchase agreements. And we do find actually that low and lower middle income countries ordered later. So you see on average, low income countries, some of them did order for themselves rather than relying on multilateral agencies, but they ordered in May 2021. Upper middle income countries as well order in February. So there's this gap in that high income countries were moving ahead. We use a regression analysis actually to decompose the delay into these effects. So there's 2 effects here. One is that, well, if you're a low income country, you get delays later, it takes longer to deliver regardless of the time you order. The other is the part that's attributed to this fact that low income countries ordered 5 months later on average than high income countries. And we find actually in our regression analysis that only 25% of the delay happens regardless of the time you ordered, and 75% of the delay is attributed to the month the contracts were signed. So this says, I think pretty conclusively that the market was actually relatively free. You could get vaccines, but it depended on when you ordered them. And high-income countries had, some advantage, which was that they had production and they could control exports and so forth. But most of the advantage came from just putting money into the companies earlier. And they often did this, before the vaccines were even licensed. So in December 2020, there are very few authorizations. Low-income countries waited until after vaccines were approved. So, I wrote a blog in 2021 saying, the problem is not supply but demand, and that was intended to be a bit provocative, but it was to illustrate this point. So you get what you pay for when you pay for it. If supply is constrained a bit, the people who order first are going to get it, and you see, and even and as well, if you have capacity or you waive patents or something like that, that doesn't mean you'll get supply unless there are purchase orders. You see this now in South Africa, where Aspen Pharma has the COVID vaccine plant, and they have no orders to buy vaccines. So there's a capacity will only get you so far. And so I want to claim, here's my claim, is that if low and middle income countries had ordered earlier, they might have secured a better place in line, and you could have had vaccine equity earlier. Now, there's a big caveat to that. So what if they all ordered earlier, and then high income countries just bid higher and ordered, and then the prices would go higher. So that means there'd be a transfer to the pharma companies, but vaccines might not arrive any slower, any faster. I think there may be something to that. We did see that in 2021 when prices, when orders actually scaled up, so you had more demand at that time, prices stayed the same or even fell. So it's not clear that extra demand was increasing prices, though it did increase deliveries. But even more than that, there's some work by Susan Athey and Michael Kramer and others, Chris Snyder at Dartmouth, that shows that you can actually write contracts that say, okay, if I pay for this, you have to invest in manufacturing capacity to scale it, and that could benefit other people. So I really do think that if we had demand earlier, that would both give low and lower middle income countries a place in line, but also could expand aggregate supply because it gave the companies certainty to invest and scale supply for everybody. Okay. So now I want to go with some hypothesis. So why didn't the low and middle income countries order earlier? So one first is a sort of limited perceived benefit, as I showed and spoke about before. There are these big differences in the age distribution. So low income countries have half the population is under 20. And they had lower fatality rates. This is just a chart from the Lancet showing you that how fatality increases by age. And just as a benchmark, malaria can have a fatality rate of 100 in 10,000 for infants, but for COVID, that fatality rate is 1 in 10,000. So it wouldn't make sense for a country to reallocate budget from its infant malaria program to COVID. You could see why they might want to create some budget for healthcare workers or the elderly, but this age distribution can explain why some resources weren't reallocated towards COVID. Now, of course, if you could borrow and you had access to finance, then you'd still want to do this to save lives, but under a constrained budget, you might not want to. Another hypothesis is that countries had limited bargaining power or capacity. So if you're a small economy with a few 20 million people, it's going to be harder to get the attention of vaccine developers who are selling to the US, with 330 million, or the EU. It's also the case that low income countries often rely on donor agencies to deliver free vaccines, so they may not have the institutional experience of purchasing vaccines. So that's one hypothesis. But at the same time, an agency was set up as part of this ACT accelerator called COVAX, the AMC Advanced Market Commitment. A lot of language here, but that was set up specifically to overcome this problem. So they were going to supply vaccines for low and lower middle income countries, and that was potentially demand as large as the G7 or the EU. And importantly, this facility could also buy vaccines early on. It actually made a purchase for the AstraZeneca vaccine in June 2020 before it was licensed, and secured a place in line for that vaccine. But what we see, though, and this points to a third hypothesis, is that COVAX actually didn't have access to the same resources that rich countries did, at least early on in the pandemic. So while rich countries, were putting, they could borrow at very low interest rates, COVAX actually, only raised $300 million, in its first fundraising. And so here in this chart, you can see the blue line shows, and the left axis show, how much money it had access to. And you can see that the purchases of vaccines actually track that, fairly quickly. So one hypothesis is to say, well, what if they had 11 or 12 billion in June 20? They could have gotten an earlier place in line. And so this points to the third hypothesis. So I already mentioned this. So COVAX didn't have finance. There was even a specific problem, which is that donors would say, okay, we'll give you this money, but then they wouldn't give them cash. And so actually, the European Investment Bank actually set up this thing where it would lend them cash against these commitments of donors. But the many multilateral development banks, other than the European Union, didn't sort of take this on. They led more on a country by country basis, and they didn't loan to COVAX. There is an example. So in Africa, they set up a regional agency, this Africa Vaccine Acquisition Trust, to borrow, and it borrowed to buy vaccines. The World Bank, did have this policy where it said, while COVAX and the high-income countries were purchasing, in advance of regulatory approval, the World Bank actually said early on that, we need approval of, from multiple regulatory agencies before we'll finance a purchase. So there was actually a point when AstraZeneca was being administered in the UK, but had not been authorized by multiple authorities, so the World Bank wouldn't finance it. And the Asian Development Bank and World Bank broadly also, didn't, even when they said, okay, we'll finance if the WHO approves it, we won't finance prepayments, that could maybe secure you a place in line. And I'll get back to that. So what are the lessons for the future? I realize I'm going a bit slow, so I'll try to speed this up. Now with the pandemic, there's extraordinary interest in pandemic preparedness. So it's good to kind of think back a little bit to 2017. So Jim Kim, the president of the World Bank at the time, raised this fund for pandemic emergency financing, and he raised only 181 million, which is so small compared to this 18 billion that I showed you was raised during the pandemic. And that project was actually pretty successful. It bought insurance against pandemics, which paid out during COVID. So it actually paid out 258 million, so more than it took in. But obviously this was still a very small amount of money. You need to buy more insurance to have a big response. And so kind of channeling this idea, there was this independent panel of the G20, which said, okay, we should have a new fund. They want to put $10 billion a year into it, and to fund pandemic preparedness. And a lot of the things we've talked about here are sort of pathogen surveillance, interruption of wild animal trade, and maintenance of manufacturing capacity. And so far, about $1 billion has been committed. So far less than the 10 billion per year asked, but still more than people were investing in 2017. And the point I want to make in this talk is that if you want to avoid the vaccine access inequity, we need to invest in strong health systems and so forth, but we also need kind of surge funding to purchase vaccines and secure a place in line during wartime. So you can say you have this dichotomy of prevention is peacetime activities, but then when you do get that 1 in 50 year flood, you need resources to deal with it. So here's how that could work. So this is again in this new paper. We say countries could establish an advanced commitment fund. It would have minimal operations, but then as soon as a pandemic is declared, so either when the WHO declares it or there's some deaths above a certain number, you might want to do the deaths threshold, because once you create a fund, and then if the WHO, then they have an incentive to release the money by declaring a pandemic. So you could guard against that by having a number of death threshold. So that's what the fund does. Step 2 is that a financier establishes a credit line to the fund. So a loan that says, this becomes active and you can borrow when the pandemic starts. And a notional value for that is 18 billion. So the exact amount of money that Act A raised by 2021, all we're saying is just say, donors will give that again. Let's lend against that, so it's available on day 0 of the pandemic. And so, with that credit line, step 3, the fund is able to invest to secure a place in line. So it can invest in R&D, support manufacturing, and also purchase vaccines. The key point with all of these is that all the contracts should have an option to purchase with a guaranteed place in line. So it secures, the position of low and middle income countries to buy vaccines. So just to talk a bit about the financier. So this is just general, right? This is any financier could do this. The World Bank is a financier, could also be a commercial bank, private foundation. And so we highlight in the paper 4 options for them to do this, which can be used separately or in combination. So one, which I mentioned, is to say just donors say in advance, we're going to do the same thing as we did during COVID-19. That's enough for the financier to lend against that. Another would be for low-income countries to actually guarantee a credit line. So they say, okay, our agencies, maybe like the Africa Vaccine Trust, are going to do these purchases. You can lend against that. A third would be insurance. So this was the experiment of this emergency financing facility. It can be a bit expensive, but in this case, it paid off. And then D would be just that the shareholders of the financier permit them to bear the risk. So just say, we're going to take no one promises anything, but we'll lend the money. And what's interesting is that in the just from the World Bank, in the pandemic of COVID-19, sort of B and C were the main options. So we had these insurance payouts and then also lending to middle income countries and low income countries directly. But previously, we've actually used other options. So there was this advanced commitment fund for pneumococcal vaccines, which was proposed by Michael Kramer and executed in the last decade. That was actually a combination of A and D. So their governments committed some money to pay for this, but they actually didn't pay it fully in advance. So the World Bank put some risk on its own balance sheet to pay for that. Eventually, the donors did pay the World Bank back, but the bank charged a small fee to take that risk. And then the final thing I want to say on this is that a financier might not want to deliver unsafe or ineffective vaccines. So one thing they can do is say, well, I'll finance prepayment to get you a place in line, but I will commit to procure the vaccine, so pay the full cost, only after emergency use authorization. So I'm not going to actually purchase the vaccines until they succeed. So that gives, puts some risk on the developer, and also means that all of your money is not actually at risk, if the vaccines don't come through. Just a few points. I'll try to wrap up really quickly. Act A provides some examples. So a lot of the orders were of COVAX were concentrated in India, which restricted exports, as it has a prerogative to do to protect its own people. But in the next time, one approach would be to actually invest in contracts from smaller countries that can satisfy their domestic demand more quickly. And that I think is part of a broader discussion of, say, if we have vaccine capacity, manufacturing capacity in small countries, there's a double benefit because that allows countries to meet their needs faster, and expand the number of exporters. And also, subsidies could be targeted in a more progressive way. So let me summarize. We get to the discussion. There was a lot of inequality internationally. Excluding India, low and lower middle income countries did have lower deaths per capita, yet vaccine access was also unequal. So we think that actually mortality of older people was higher in low income countries. So though there was an overall effect that was lower, there was still people going without healthcare. And also, income convergence is forecast to return. So there's sort of inequality will decline over time in the long run in aggregate between countries. And then, looking at the cooperation, so there was this forbearance. I told you that doesn't seem to have been particularly effective in lowering costs, but the development banks did, provide this cheap finance, but importantly, not for at-risk purchases of vaccines. Donors committed 18 billion to Act A, huge amount, more than previously to prepare for pandemics, but this came slowly, only after 18 months. And so, but still, despite all of this, 24 months into the pandemic, vaccine supply is not a constraint. So there was a brief window in 2021 where that was an issue, but now, it's about, the sort of final delivery, last mile delivery, excuse me. And then C, this is my claim, is that the response could have been even faster and more equitable had funds been available for Act A and for countries. Earlier, we could have incentivized an earlier expansion of supply and also secured countries a place in line. So with that, I'll stop. Thanks so much.
Thanks, Tristan, for that retrospective and perspective view. As I mentioned at the beginning, we are really pleased to have Kent Ransom here as a discussant. So Kent, over to you for some reflections.
Great, thanks Dion, and thanks Tristan for providing me the opportunity to comment on this interesting and highly topical presentation. I was asked to comment based on my involvement in the World Bank's collaboration with Gavi and the COVAX facility. I'm not an unbiased discussant. As an alternate to the World Bank's Global Director, Health, Nutrition and Population, Juan Pablo Uribe, I represent the bank on the board of Gavi. The board of Gavi oversees the Gavi Secretariat and has the ultimate responsibility for decisions and effective implementation of the COVAX facility. As Tristan mentioned, COVAX is the vaccines pillar of the ACT Accelerator. Gavi, CEPI, the Coalition for Epidemic Preparedness Innovations, and WHO co-lead COVAX. Gavi coordinates the COVAX facility, which is the mechanism for securing COVID vaccines, either by procuring them or through receipt of donated doses and equitably allocating these vaccines. COVAX has now delivered over 1.5 billion COVID-19 vaccine doses to 145 economies, including over 1.3 billion doses to AMC countries, advanced market commitment countries. These are 92 low and middle income economies, contributing significantly to coverage rates achieved in the AMC countries. And they currently have coverage rates of average coverage rates of 54%, with at least one dose, and 46% fully vaccinated as of 24th of May. Although overall coverage between and within countries remains uneven, as does the coverage of high-risk populations. I certainly agree with the primary finding of your analysis, that is, that the multilateral vaccines response could have been even faster and the results more equitable had funds been available in early 2020. That earlier orders would also have secured low and middle income countries a more equitable place in line, benefiting high-risk populations in those countries. But I'm also glad that your analysis highlights that 25 to 40% of the delay in vaccine deliveries to low and middle income countries occurred independently of the time they were ordered. Delays were certainly also about policy and process and power. In terms of power, you've mentioned the home market effect, which is no doubt significant. Delays certainly also had to do with setting up regulatory and legal frameworks, deployment capacities, so long-term investments in routine immunization, and vaccine acceptance, among other things. Your analysis didn't consider, as one of your hypotheses, whether countries would have been ready to receive and deploy vaccines if they had access to them 6 months earlier. While countries awaited vaccines, they invested in deployment capacity, communications to build receptivity, training healthcare workers, regulatory requirements, etc. Some of the delay with which low and middle income countries placed orders may have reflected their own readiness to deploy the vaccines, having firstly observed the impact of vaccine deployment elsewhere while assessing their own perception of need. Clearly, a multilateral pandemic vaccines response should ensure financing not only for vaccine procurement, which is the focus of your presentation. I thought it instructive to look at some of what Gavi is planning for pandemic preparedness as part of ongoing discussions about the global architecture and financing for pandemic preparedness and response. Gavi's begun to articulate its potential role. And this will, of course, be informed by reviews and independent evaluations that are planned for COVAX. What Gavi proposes is, firstly, that it has a vital role to play in building countries' capacity to respond in emergencies by strengthening routine immunization programs, increasing their efficiency, focusing on equity, and reaching missed communities. Secondly, Gavi has a core role in addressing inadequate manufacturing diversity in the face of COVID-19 and calls for support to African vaccine manufacturing. Gavi's experience in market shaping for vaccines can be leveraged to inform the intentional design of a vaccine ecosystem that supports the sustainability of African manufacturing facilities and the health of the global market more broadly. Thirdly, Gavi's financial instruments and capacity to innovate at pace can play a role in future pandemic response. I thought it worth mentioning some of Gavi's innovative financing mechanisms given their potential role to provide financing for future pandemic response. Gavi has a long track record of financial innovation, most notably forming the International Finance Facility for Immunization, IFIM, in 2006, with the World Bank as its treasury manager. IFIM's pioneering work to create vaccine bonds through raising finance on capital markets backed by long-term donor pledges meant that a $1 billion front-loading tool was available to provide additional resources to the COVAX AMC. Recently, Gavi announced a new COVAX rapid financing facility. This is financed by the U.S. Development Finance Corporation. This is the first front-loading arrangement that Gavi has designed that provides access to liquidity from the moment a donor pledge is publicly announced, rather than only when grant agreements are signed. This will allow COVAX to front-load up to $1 billion in donor pledges for up to 2 years in increments of $350 million at any one time. Tristan, you also mentioned the EIB facility. This is a facility that allows Gavi to front-load pledges and draw down cash, but to do so on the basis of signed grant agreements. The capacity of the EIB facility has recently been expanded from 440 million euros by a further 1 billion euros. And there are conversations about having both a front-loading and a quasi-contingent capacity to that EIB facility. We also established the cost-sharing mechanism through which countries could procure extra COVID-19 vaccine doses using their own funding, including World Bank financing. This mechanism could also potentially be kept warm for use in a future pandemic. So in fact, many of the aspects of the Advance Commitment Fund that you proposed are already in place at Gavi. You've not mentioned the World Bank white paper on the proposed financial intermediary fund for pandemic prevention, preparedness, and response. So I did wonder to what extent the proposed mechanism addresses recommendations that you've made in your presentation. My reading of the white paper is that it's more about how the fifth will be governed rather than what it will do or the details of what it will do. I do note that they recommend procurement of pandemic countermeasures, presumably including vaccines. And it's clear that in the first instance, they are planning for grants in, grants out with no contingency financing. But I'd be interested to hear your reflections on that white paper. Finally, I hope that your team at DEC and others will be involved in drawing lessons on what worked and what didn't work in terms of financing at country level in low and middle income countries. Faced with little or changing information about disease epidemiology, vaccine supplies, demand for vaccines, how were decisions made about allocating to vaccine procurement and deployment? And what impact did this have on financing of health and other sectors? What sorts of technical assistance at country level might have helped to better prepare and respond? I think that one of the key lessons learned from the COVID pandemic is that when a government has a say in how COVID tools are financed and procured and allocated, this ownership and agency is then reflected in-country deployment of these tools. So I'd also encourage the authors to think about how countries can be involved in consultation around your analysis and papers. Thank you very much.
Thanks so much, Ken, for those insightful comments, both reflecting and then very interesting to learn about all the different mechanisms that you describe, and interesting to think about them in relation to what Tristan was putting forth. I'm going to turn it back to Tristan if you want to pick up on a couple of Kent's points, but I do want to encourage people, if you do have a question, please raise your hand using the raise hand function, or signal in the chat that you'd like to come in if you have a question for either Tristan or Kent. I hope, Kent, you don't mind if people direct some questions to you. But with that, let me turn it to Tristan for some reactions, and then we'll open it up. Please let me know.
Yeah, thanks. Let me respond quickly and to those 3 points I think I have, and then we can. Yeah, I'm eager to hear the audience. So yeah, I think on absorption capacity and the ability of countries to absorb, vaccines, that's certainly an issue. And I should have highlighted it directly. But I think one thing that's interesting to point out is that actually even low-income countries actually do have a lot of experience with mass vaccination campaigns. So there's an example in 2013 that Burkina Faso immunized the whole population under 20 against meningitis in less than a month. And now that took a lot of planning and additional resources, but it can be done. And so part of I worked actually before the bank on the polio campaigns in Nigeria. You can do them if you have planning and resources. And so as long as we make sure that this kind of surge efforts are part of countries' planning, I think it's sort of very feasible that in the next pandemic everyone will be can be ready to go. You mentioned the World Bank Financial Intermediary Fund. So these are sort of my views as a researcher, and I want to make very clear I'm not speaking for World Bank policy. There's been a lot of public discussion which is ongoing. That fund, as I said, as there's about $1 billion that's been raised for it, and there's a lot of things that people have proposed. And as you said, the discussion is mostly about how it will be governed, but not actually what the money will be spent on. And Amanda Glassman at CGD actually wrote a nice comment on this, which I thought was helpful, which is that the fund can actually be targeted at these prevention activities, so surveillance and safety in markets that sell wildlife and so forth. But actually, we can address this kind of surge of response through existing instruments and products, as long as we make the right modifications. So if multilateral development banks like the World Bank would finance prepayments before licensure of the vaccines, that would allow countries to buy early on in the pandemic. You mentioned the IFM and EIB structures. Those exist, and you can lend against donors. Commitments, as I said, the World Bank has done this before for the immunococcal advanced commitment. So I think we actually can respond without using the additional funds from the FIF, but we do need to make sure that we don't have restrictions on how money can be used in order to do that. And then third, just kind of tying back to what I said about absorption capacity, there's so much good research coming out of DEC on last mile health delivery and incentives for healthcare workers. And this is the bread and butter of both pandemic response and also global health generally. And we saw that, yes, there was this period in 2021 where we needed supply and all this financing would have been helpful, but now we're just kind of back to the same problem, which is that you need to vaccinate everybody, and that's a hard thing to do even in high-income countries. So I think the bulk of research that DEC and others are providing can be really useful there, and is very important, as long as we make sure we get this response financing correct. So overall, I'll open up to everybody else. Thanks.
Yeah, just to pick up on that last point, I mean, Kent, you're right. I mean, I guess we are going to be going into a phase now of looking back at lessons learned, but we do have a rich tradition within the research department of looking at health services and improvement, the quantity and quality and access to and the quality of service delivery. That's ongoing, and we obviously very keen to keep doing that. And as you say, using this period to look at exactly what happened and lessons for the future on that front as well. I don't see any hands raised. Ryan, I don't know if we've received any questions through the YouTube chat function. I want to just give people a chance to come in.
I see one from Samir Chandra.
Yeah, Samir. Go ahead, Samir.
Hi, this is Samir Chandra. Can you all hear me? Well,
Yes, we can.
Oh, thanks. This is Samir from Global Geographic Society. We are a Virginia-based nonprofit organization, and I'm an independent researcher working on poverty alleviation through skill development. My question is, what changes you see in this post-pandemic scenario on the global supply chain, especially development of the local supply centers and local manufacturing, and its impact on poverty alleviation, especially in the third world countries?
Yeah, thank you. So I think that's a super important point. As I said, there's this, so in international trade, there's this thing called the home market effect. And that means if you have increasing returns to scale and production, that means that actually the countries that do the most exporting will also be the ones that have the big domestic markets. And so that's really what you see in health products, and in vaccines in particular, that the US, China, EU are the big producers, and India, they have these big markets. At the same time, those are the countries that will also, they need to serve their own populations. And so in emergencies, because they have big populations, it will take longer for them to produce enough to provide for their populations. And so I think from that perspective, there is actually a lot of benefit in subsidies and efforts to make sure that every country has a little bit of vaccine production capacity, so they can both provide for their own populations, but also export. I think the challenge with that, though, is that in order for local vaccine production to be sustainable, it has to have continued demand. So you can't just have a factory sitting around for 30 years until the next coronavirus pandemic. You need to actually use it to provide, the basic, childhood immunizations, measles and yellow fever and these sorts of things. And so I think that conversation so there's a lot of effort to diversify production capacity, but that will need to be accompanied by a concerted effort to actually make sure that those local producers have sustained demand and they can build their capacities and keep them warm over time.
Thanks, Tristan. And I believe one of the challenges will be of knowing the technical know-how and the equipments and other facilities which can really facilitate or support these kind of manufacturing in those countries.
Yeah, I think Kent mentioned that COVAX is or Gavi in general, which buys vaccines for low-income countries, is thinking about how it can procure from a more diverse pool of countries, exactly in that spirit.
Can I pick up on this and turn this question a little to Kent, but in a very specific case, which is the South African situation right now, where they seem to be developing this capacity, but there seems to be no demand. And how do you have any thoughts on that, and how to change that situation such that this capacity actually is sustained? Because if there's no demand, it'll wither for sure.
The conversation then at Gavi is not just how they can buy vaccines in a pandemic from manufacturers in low and lower middle income countries, but how there might then be support vaccines for routine immunization purchased from those facilities, so that the facilities are ever kept warm. On South Africa, I'm not sure what solution there might be for the lack of demand for the vaccines out of Aspen.
Great, thanks. Galina, did you want to come in and put your question to the group? I see you've put a question in the chat, but
There's also Shabtai has his.
I just want to give Galina a chance to come in if they want to. Okay, we'll take that as more of a comment then. Shabtai, do you want to come in?
Yeah, thank you very much. I just wanted to ask Tristan if he can maybe expand a little bit more on what he was talking about with regards to the, getting that the financiers can make it so that countries can purchase even before there's a authorization, and how exactly that could work with the other problem that he was talking about, that a COVAX facility that might be needed would, there's this country lending issue. So how to reconcile, on the one hand, the bank has a need to lend specifically to countries, but then maybe you will need more money even if a fund is established. So how to sort of get around all of those issues, given the bank's own constraints? Will this require a policy change? Will this require some sort of different view within the bank over whether it lends only to countries or not? Sorry if that was a bit convoluted, but
Right. No, that makes sense. I don't want to speak about World Bank policy, so I'll speak generally. But I think there's two separate issues that you raise. So one is that all of the high-income countries, not all, but most, took a risk at the beginning of the pandemic by paying for vaccines that might never have been successful. And this really did pan out, right? That you had, the CureVac, for example, which didn't work, and that was money, and it was not delivered. And somebody has to pay for that. And in this case, it was the high-income countries. The World Bank said, we will not finance. They declined to finance purchases or any payment before licensure, which means you're not subject to that risk. Now, as I said, you could say, well, I'll pay let's say 20% of the cost now and only 80% once it's authorized, so you can manage your risk in that way. But there's still some money that's put at risk. So that's kind of one policy where you just have to choose. Are you going to let purchases happen? And this could be either purchases made by an individual country. So say Nigeria wants to buy more vaccines, but they haven't been authorized yet, so it's going to give money to get a place in line. You have to decide whether that's okay, or it could be a loan to a regional group. Now, the other thing we raised was sort of whether you lend to individual countries or groups. As Kent raised, maybe a lot of countries, because they were seeing, okay, maybe I haven't had that many fatalities yet. Maybe I'm waiting to see how the planning will go, and so they wait. In that situation, I think there is a benefit to having a global or a regional organization that takes some risk and moves faster than the other countries. So COVAX, like it did purchase in advance, and it was one of the first sources of supply that lots of countries had, because it had moved so early. Now it had some bad luck, which was that its first purchase was in a country that later restricted exports, but had it been a more diversified pool, or it just could have turned out differently. So I think you need both. I think you need a willingness of finance to lend before vaccines are authorized, to get a place in line, and also to incentivize supply. But you also need these kind of global or regional agencies that can make purchases ahead of countries. Another example of this is so PAHO, the Pan American Health Organization, bought vaccines in advance of countries ordering them. So did the African Union, actually. So they said our members haven't figured out how much they need, but we're going to go into the market and secure it. That's an area where cooperation and also an independent management that can move faster than countries is beneficial, but that does have some risk, and someone needs to bear the risk associated with it. Anyone else, I guess?
Yeah. Anybody else have a question they'd like to put to the group? Doesn't look like it. If not, I suggest I turn it back to Tristan, maybe, and then Kent, if you don't mind, just last word to our discussant.
Yeah, thanks. I mean, I just want to really emphasize this point that, I think there was huge inequity and inequality in access to vaccines for about a year during COVID, and that was due, as Ken said, to policies that high-income countries took, to secure vaccines for themselves, but a lot of that had to do with getting money into the market earlier. And it is my hope that in the next pandemic, with the new resources and interests that we have, we'll be better able to get money into the market on behalf of low and middle income countries. And I also admit that is a little bit of a competition. You need high income countries may not want low income countries bidding against them, at least early on. But we do need to make sure that resources are available to do that. And I think if we do, it can benefit everybody by expanding supply, but also increasing equity. So thanks.
Thanks, Tristan. Kent, any last words from you?
No, just to again thank Tristan and the team for the very timely work. I think this can feed into a lot of the global discussions that are happening right now about financing for any future pandemic.
JP has one question. It looks
Yeah, I see we have a late entry here. JP, do you want to go ahead?
Oh, you're on. We can't hear you. You're on mute.
Oh, thanks, Dion, and hello to everybody, and to Tristan and Kent. My appreciation for the very interesting discussion. I did want to come out of silence and express my appreciation to both of you and to Dion for sharing it. I do believe that there's an incredible multi-causality here, many variables connected. It's very nice to try to dissect them, but at the end of the day, when they appear, they all happen together. So we will need to continue thinking on these hypotheses and the different assumptions and the scenarios moving forward. I do want to highlight Kent's point on the country strengthening capacity in the response. I think it's a core element as we move forward. It's going to be very important, Kent, for the evolution of the white paper, and more especially for the, let's say, the shared effort that we all bring around in strengthening, again, country capacity around PPR. It's going to be extremely important. And I also believe that the overall, Tristan, let's say, trade variables, including the production and being able to control the national production of supplies, not only vaccines, as we saw throughout 2020 and 2021, is a very important variable to also consider in detail. So I wanted Dion basically to bring these considerations at the end. And again, thank you for the space. And we for sure need to keep on thinking on all what we can learn from the past 2 years as we move forward. Thank you very much.
Thanks, JP. Just for those who don't know, JP is the global director for Health, Nutrition, and Population here at the World Bank. So really pleased that you could join us today. And thanks for that intervention. And as the director of the research department, let me just say, I really look forward to working with all of you on thinking about these issues, both retrospectively learning and looking forward as well, what we can do to improve the quality of health services in developing countries, and this aspect of it as well, which is this sort of surge capacity that's needed in times of crisis. So with that, let me close this session today. For those of you who follow these policy research talks, this is the last one of the season. We're going to take a hiatus over the summer, the northern summer months, and we'll be back in September with a new session that will be announced. As Ryan has just put in the chat, you can link to all the event materials at this website. And just thank you for your attendance and participation, and thanks Tristan for the talk, and Kent, really thank you so much for making the time to both come here today, but also think carefully about how to position this work more generally. So thank you very much, everyone, and have a good rest of your days.
Thank you.
Thank you so much.
Thank you.
Thank you. Thanks, everyone.
Bye-bye.